American medicine produces some of the most advanced treatments on Earth, but it operates atop a structure that cracks under its own weight. It is the most expensive healthcare apparatus in human history, yet it produces the worst overall survival outcomes among its peers. This scatterplot charts international data from the OECD. The OECD is the Organization for Economic Cooperation and Development, an intergovernmental group of mostly high-income countries. As you can see on the horizontal axis, the United States spends 17.8% of its total GDP on healthcare. That is nearly double the average of its economic peers. Look at the vertical axis. Despite that massive financial input, the U.S. sits at the very bottom for life expectancy. It also records the highest rates of avoidable mortality, maternal mortality, and infant mortality of any developed nation. Diagnosing why this happens requires stripping away domestic political rhetoric. We have to examine the cold structural mechanics of how global healthcare actually operates. While there are roughly 200 countries on Earth, there are only 4 distinct ways to organize, fund, and deliver medical care. Analyzing these 4 structural models provides an objective baseline. It is the only way to measure exactly what Americans are buying with their extreme premium costs. The United Kingdom operates on the Beveridge model. It treats healthcare entirely as a public utility, like a fire department or a public library. The system was designed by social reformer William Beveridge. Under his blueprint, the government acts as both the sole funder and the provider of care. Hospitals are publicly owned, and doctors are government employees. Because the system is funded entirely through tax revenue, patients never see a medical bill at the point of service. This creates strong equity for preventative, population-level health. The trade-off is time. Because the government dictates strict cost controls and caps what doctors charge, care is rationed by waiting lists. Patients routinely face extended wait times for non-emergency specialist care. Canada operates on a structural hybrid known as the National Health Insurance, or NHI, model. In an NHI system, citizens pay into a government-run insurance program, but the hospitals and doctors operate in the private sector. The government acts as a single, massive payer. This gives it extreme market power to aggressively negotiate and drive down pharmaceutical prices. Both the Beveridge and NHI models eliminate the risk of individual financial ruin from medical debt. In exchange, the population accepts that specific services will be limited, and specialist care will require waiting in line. Continental Europe largely utilizes the Bismarck model. Instead of heavy taxation, this system is funded by mandatory payroll deductions that are split directly between employers and employees. Named for Prussian Chancellor Otto von Bismarck, the system relies on private doctors and private hospitals. Citizens pay into decentralized insurers called sickness funds, with one strict rule. These insurers are legally barred from making a profit. The financial risk profile for the patient is remarkably low. If you are admitted to a hospital in Germany for a multi-day stay, your total out-of-pocket cost is exactly 30 euros. There are no deductibles to meet. Delivering a 30-euro hospital stay requires intense regulation and extreme operational efficiency across the entire medical sector. Absolute financial safety strips away luxury. In a Bismarck hospital, patients share rooms. The food is basic. You will likely not even find privacy curtains between the beds. The Bismarck model prioritizes financial predictability over aesthetics. Patients trade the luxury of a private hospital wing for statutory sick leave and capped medical bills. The United States does not use a single, unified system. It is a fragmented patchwork of all the global models, strictly segregated by demographic class. For citizens over the age of 65, the U.S. government acts as a single payer through Medicare. This is a national health insurance model, operating exactly like the system in Canada. Working Americans who get insurance through their employers exist in the Bismarck model, with one massive exception: U.S. insurance companies extract a profit. Meanwhile, the 8.6% of Americans who are uninsured are left to navigate a harsh, entirely out-of-pocket market. The clinical advantage of the U.S. model is speed. If a patient holds premium insurance, they receive unhindered access to rapid specialists and cutting-edge diagnostics. This speed is driven by hardware density. The United States deploys about 38 MRI units for every 1 million people, ensuring immediate availability for those who can pay. The trade-off for this density is catastrophic. To afford the hardware, insurers impose massive deductibles. Patients routinely delay necessary care because they cannot afford the out-of-pocket cost. Routine issues metastasize into unmanaged chronic diseases, driving up avoidable mortality rates. The United States does not ration care by wait times. It rations care strictly by price. It provides a premium concierge ceiling, built atop a highly fractured foundation. Because these structural models operate so differently, they rely on standardized patient experience surveys to measure their own operational quality. In Europe, they use the PEQ. In America, it is the HCAHPS. The PEQ is the Patient Experience Questionnaire, and the HCAHPS is the Hospital Consumer Assessment of Healthcare Providers and Systems. Both are rigorous surveys that force hospitals to compete directly on quantifiable patient satisfaction metrics. Globally, this standardized competition works as intended. It universally incentivizes better doctor-patient communication and a stronger bedside manner. In the US, however, this metric distorts the market. Because hospitals are fighting to attract well-insured, profitable patients, competitive survival forces them to prioritize visible luxury over underlying clinical efficiency. Market incentives dictate that capital flows toward hotel-like lobbies and private suites, while critical emergency infrastructure remains severely overwhelmed and underfunded. American patients often enjoy private rooms and specialized menus, but the data shows those visible amenities fail to correlate with better baseline survival rates. There is no perfect healthcare system. Every single model must ration care in some capacity. To evaluate which system works best, you have to look at your own medical and financial reality. This chart maps the need for financial predictability on the horizontal axis against the demand for specialized access on the vertical axis. If you are a healthy high earner who demands immediate diagnostic access and luxury amenities, you sit in the top right. For this specific demographic, the U.S. system offers an unmatched ceiling. If you are risk-averse, or if you have high recurring medical needs, you fall in the bottom left. Here, the unified European models offer a drastically superior return on your investment. Consider the burden of chronic illness. The predictable pricing of unified models protects patients from the ruinous deductibles required to manage daily conditions in the U.S. market. Until the United States implements structural cost containment, individuals must objectively audit their own health risks. If you don't, you run the risk of paying premium rates for luxury accommodations on a sinking ship.